last time we ended out. Well, I can just look at my screen. We ended up talking about a bunch of solid masses. Well, it's inflamed cyst, papillary apocrineal, galactocele, sebaceous cyst, mastitis, abscesses, Mondor's disease, hematoma, seroma, fat necrosis, and that can turn into an oil cyst or a fibrotic space that looks a lot like cancer. And we had scratch, I think that's his name, and solid masses here. We talked a little bit about fibroadenomas, the #1 most common benign tumor of the breast, and then adenomas, which are almost the same thing. They're just without the fibrotic tissue. And a secretory adenoma, and that's going to happen during lactation. Phyllodes tumor is really the same, almost the same thing. It just grows faster, and it can become tumor, but it's really, it has the same cellular makeup as the fibroadenoma. So, and they look a lot like fibroadenomas, just huge. Hamartomas we mentioned, and those are, once again, kind of a similar. Hamartomas are, they have all the cellular makeup of a breast, and so a lot of times they look like a breast within a breast, because it kind of is. It's like a tumor of, it's a tumor of like a miniature breast inside the breast. I mean, what else can you say? And we have different ways of naming it depending on the number of, or the percentage of fibrotic versus glandular, which is versus fatty tissue. So we can name them 3 different ways. And we mentioned lipomas. Those are just fatty tissues. You get lipomas anywhere, not just the breast. Intraductal papillomas. This is going to come up again today. So those are the intraductal papillomas, are benign epithelial tumors, like kind of like a polyp. May rarely transform into cancer, and we're going to talk about that today. Intraductal papillomas tend to occur close to the areola. They just, you know, that's where all the ducts are going. Unless you have a different type of intraductal papilloma, and that's peripheral papillomatosis. And those occur in younger women, but also a little farther out on the periphery of the breast, in the so more in the TDLUs, and those could be multiple. All right. So today we talk malignancy. Getting a little, I'm going to skip some things today, guys, because I am getting, well, it's not just because I'm getting tired, it's because we have to keep moving, but I am, well, I wrote in my notes when I'm skipping. Yeah, I wrote in my notes. One thing I'm skipping is the aspiration, fine needle aspiration, and kind of procedures that you're going to help out with. You could read that on your own. Okay, so malignancy. Some malignancies of the breast are not bad, but others are terrible. So we're going to talk about those. Malignancy, the TNM, or I would say the TNM system. Wrong pen. TNN is a kind of a system for evaluating malignancies. They look at the tumor size, nodal status, whether or not the lymph nodes have reacted, and Some cancers go straight to the nodes real quickly, and other cancers grow and grow and grow, and they don't even go to the nodes. They'll actually metastasize somewhere else first. And then, of course, metastasis. So TMM is the system. So if you ever hear that, that's what that means. All right, so the very first cancer is non-invasive cancer. That's also called carcinoma in situ. Carcinoma in situ. So like carcinoma in place, right where it started is still where it is. Now this is the kind of cancer, if you're gonna have it, this is what you want. Because this is very survivable, both LCIS and NDCIS. So LCIS is lobular carcinoma in situ. And it's not a true cancer. And in my notes I put yet, and that's the important part. It's not a true cancer, and if that was the end of the story, then they would just walk away from it and say, okay, fine, you have LCIS. But there is an increased risk of cancer once you have LCIS, and so increased risk of certainly of LCIS transforming into a cancer. LCIS and lobar. So these are occurring, you know, in pretty much all the cancers. Almost all these cancers are occurring in the ducts, in the lobar, so you know, close to the acini. That's where most of these cancers are occurring, in the epithelial tissue of the glandular tissue. These may be multifocal, and also bilateral. Now that doesn't mean that it was multifocal or bilateral because it metastasized. It just means that if you have the genes, or if you have whatever caused LCIS to happen, it's probably happened more than once, and so that's why it's multifocal and possibly bilateral as well. There are other cancers that do metastasize, and that's why you see them bilaterally, is because they actually went from one breast to another, but not in this case. These occur in reproductive age women. So not the 50-year-olds or 60-year-olds, but more like the 20s and 30s, 40s, I guess, too. Oh, and yeah. LCIS. Here's an image here of LCIS, and there's an architectural distortion, but the tumor is hard to see. So, you know, it would be very difficult to, you know, where would you put your calipers? Calipers. Where would you put your calipers on this? You really can't see the tumor, but there's a distortion here. This is, you know, this echogenic, that's a fibroglandular tissue, and then there's like, I want to call it a shadow, because look, there's really no shadowing behind this. It's just something's going on. So I guess we could try to measure that, but it'd be a little difficult. I don't know if it, not a true cancer. I think it's not a true cancer. And they say that really because it's in situ. And I should really say it's not really, oh, well, let's say that actually, that kind of would help. LCIS and DCIS, totally inside ducts. Both of these are totally inside the ducts. That's why they call them, it's not really a true cancer. And they might just, they might never really break out of the ducts. And even though in a sense it really is cancer, but on the other hand, if it doesn't grow and invade and metastasize and all that, then is it really a cancer? It's kind of like in between. And then this would be ductal carcinoma, DCIS, ductal carcinoma in situ. Okay, sorry. This is number one. Most common non-invasive, the most common in situ. Because remember, non-invasive cancer is basically carcinoma in situ. It's the same, carcinoma in situ is the name, but it's not invasive is what they're calling it. So, and that's why they call it kind of quasi cancer or cancer light. Most common non-invasive. These guys, you're a little bit older. So post menopausal. And very treatable, if you even know it's there. These guys are not always easy to see on mammo or ultrasound, but I did pick up a couple of images here. These are good images of things that first of all, this image is too dark overall, but how would you even find this? Intraductal calcifications, tumor not appreciated. That's doctor talk. If it's not appreciated, it means they can't see it. But yeah, they're really not, there's nothing to see here, folks, except some little dots along the way. You have to look really close to even see those. And so, perhaps they were seen on mammography they saw dot, 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 something like that. And they had the sonographer take a really close look at that spot exactly. Or this was an awesome sonographer and they actually caught this on their own. I don't know. But you would not be crucified for missing that, although obviously we try not to miss it. This one, we are seeing a bit of a tumor. Not that it's easy to see, with calcifications as well. A little bit larger calcifications. I don't know if I'd call those microcalcifications unless they're clustered. There might be clustered microcalcifications. But intratumoral calcs, once again, really hard to find this if you're not given a heads up by mammo. If you weren't given a heads up, you might not. But look at the thing, actually, look where this arrow is pointing. There's the tumor, but look how the the fascia, let me get myself a little bit. Look at the fascia here. It's pushed up, but it's not invaded. This did not cross any kind of barrier, so it has a mass effect without putting little dendrites, little fingers going in through the tissue. So that's a good sign when you do see a tumor like this. Probably a little cyst formed because this is blocking the duct. So and that's kind of a good lesson for us. If you find a cyst and a small cyst anyway, and you're looking at it, and take a close look around the cyst. Is there anything? Is that cyst evidence of is it just a simple cyst, or is it actually a duct that's been blocked and has been opened up? So, oh, I need to get back to. So, very treatable. However, oh, I have a however. There are two subtypes. Two. There is comedo. Comedo. Anyone has anyone ever go to a dermatologist because of you were a pizza face in high school? Comedo, and when dermatology is talking about really like filled in blackheads or whiteheads, the comedo is paste-like material. But when it comes to DCIS, comedo is kind of the same thing. So when they open these up, there's when they pull them out and then open them up, they're filled with paste. And if they're completely filled with this pasty tumor, it's called comedo, and this tends to be a high grade. It's kind of weird terminology, high grade with non-invasive carcinoma. So high grade what? I guess high grade means that it's growing, it's filling everything in, but still not invasive. But as you might imagine, high grade is more likely to I'll use the word transform into invasive. In other words, and this is common, not all cancers, but some cancers, they have different subtypes, and they even have precancerous cells where it's not cancer yet, but we know statistically it's probably going to turn into cancer. And so this is kind of that same situation where you could have precancerous cells, which is kind of what they're calling DCIS when they're saying ductal carcinoma in situ, and it's not a true cancer. It's kind of a pre-cancer state. It's growing a little bit out of control, but not totally out of control. But something can snap, and then it becomes an invasive cancer. So just because they see it doesn't mean that, just because it's non-cancer, doesn't mean they're not concerned. They do want to remove it if possible. And then non-comedo. And by the way, these are doctors with the slide of a sample in front of them. This is not something we normally would know for ultrasound. Is non-comedo is low grade and less likely likely to become invasive. And we'll see some of these images. Like I know I've said it before, like 10 times. We're not going to know the difference between one kind of cancer and the other, and neither will the doctor, not until a needle is put into it. Okay, on mammo, microcalcifications, and that's about it. The mass itself probably won't be seen. On sonogram, same thing. Microcalcifications. And I have written down my notes, which I basically already said earlier. If mass too small, basically hard to see. So like I said, you know, this sonographer was probably pointed to this exact point. Said, look right there. Probably on this one too, because to examine the entire breast and find that would be really impressive. Okay, so let me just back up. I want to make sure, because these are the more common things. So LCIS, lobar carcinoma in situ, DCIS, the more common in older women, ductal carcinoma in situ. Both of them are kind of a pre-cancer state. Well, they're not cancer yet. They might not ever become cancer, but they can. Both of them are very difficult to find on mammo and on ultrasound, because we're talking about not only small tumors, but not a lot of distortion of the architecture of the breast. Okay. Paget's disease, or would that be Paget? You know, I don't know. I never thought about it. That looks like Paget seems like a French name, right? That is basically, well, this is here. This is a picture of it. Paget's disease, and so it's cancer. Cancer has reached the nipple. It doesn't usually start with the nipple. It usually starts in the subareolar ducts, and so nipple cancer most likely caused by retroareolar DCIS. So likely to be caused by retroareolar DCIS. So and I want to say, I didn't write it down, but I want to say that actually men are actually more likely than women to get this. I'm not sure though. I better be careful. So obviously, the nipple is being affected by nearby cancer, so it can become red, crusty, or how do you spell eczema? Eczema-like, crusty. There could be discharge. But in general, they're probably going to, let's see, I have a little bit too close. Let's get this guy like that. All right. In general, these folks, these patients are going to head to mammo or even MRI to take a look at what they have there. Some examples of IDC. So invasive cancers, these are the ones we really don't want. Now we're starting to get dangerous. And so if you see the term IDC, that is invasive ductal carcinoma, IDC NOS, I'll back up here a little bit. IDC NOS, not otherwise specified? Yes, specified. Specified. Oy. This is going to drive me crazy. My computer is slow. Now it's even worse. All right, not otherwise specified. And these really are the same thing. IDC, invasive ductal carcinoma, no special type. No special type. And all this is really saying, guys, and it's kind of like this is the part we care about, invasive ductal carcinoma. This is where the doctors have looked closely at it, and assuming they've taken a biopsy, they don't know. They don't know. They know it's cancer, but there's no specific variety to it, so they just simply call it invasive ductal carcinoma. What was it? Number one cancer, and number one invasive. So invasive ductal carcinoma is the number one breast cancer overall. And the number one invasive cancer overall. So there's a couple of different varieties. Just like so many other cancers, they have varieties to them. Slow-growing varieties, these guys create the really dense shadowing. So let's see, dense, like deeply shadowing. Tumors, and it's because the density or the deep shadowing and the deep I would say the deep shadowing. Let's see, shadow. Let's put an arrow here. That is caused fibrosis. So for some reason, the cancer fibrosis and breast cancer fibrosis is super hypoechoic when we see it, and the shadow is really thick. I mean, like absolutely as thick as a shadow can be on ultrasound, as anechoic as can be. The faster growing varieties, they're still going to be dense, they're still going to be shadowing, but not as much. But they can create more vascular and halo-inducing. Let's put and there. Halo-inducing. In other words, when you have something growing quickly, it produces a halo effect, a dark halo around it. And that's, you know, edema or compressed tissue, a little bit of both. So they're a little more halo inducing, but like I said, it's still a pretty hypoechoic. It's still probably going to shadow. And it's probably not shaped like that. It's probably shaped more like that. On mammography, what are they going to see? They're going to see microcalcs. Radio dense. In other words, very white on the screen, on their screen. They're going to see spiculations. And straightened Cooper's. In other words, it's pulling on Cooper's ligaments, so they're all pulling straight down towards the cancer. And Sano, I just have one line here, and that's basically everything. Everything bad. So they tend to be hypoechoic, shadow, spiculations. By the way, on ultrasound, sometimes we do see spiculations. Other times, let's see, what else do I really don't want to say anything else anyway. So let's come over here. Let's come over here and look at some of these. Invasive ductal carcinomas is what I just did there. Yeah, I'll zoom in on this guy. Not that guy, this guy. So this guy has definitely I would say there's some microlobulations. There are macrolobulations too. Here's something I didn't say to you, and I thought about it. I wrote it down somewhere too, but I did tell you that large macrolobulations are good. However, there's a number that's not so good. That picture might be large lobulations, but there's a lot. And honestly, I can't remember what the cutoff value. I think it might be greater than 3 lobulations are starting to get a little more concerning. And this guy has, I would say, some microlobulations, little tiny microlobulation right there. But on top of it, it's got 1, 2, 3, and 4. So it's got a lot of stuff going on. The reason, I just erased something I didn't want to erase. The reason I wanted to zoom in on this one, though, there are spiculations on this picture, but hard to see, partially because this picture is not great. It's been copied 100 times. But a lot of times you have these hypoechoic structures. Look, this one doesn't have any shadowing, but that's just luck of the draw. A lot of times, though, around the outside, there's like an echogenic halo. And what that is, that echogenic halo, what it really is like hundreds and hundreds of tiny little spiculations, these little projections going out. They're too small for us to see clearly. And so what we end up seeing is this fuzzy, kind of a fuzzy look on the outside. Let's see if we have another example that might do better. Here, actually, we can see, like, we're not really clearly seeing spiculations, but trust me, they are there. But definitely, I mean, this is, look at this, look at that. That's a mess. You got sharp angles, you got microlobulations, you got projections sticking out. Not a whole lot of blood flow, but there is blood flow inside of it, so we know it's not it's not an abscess. Not a lot of shadowing, but like I said, luck of the draw. Sometimes they don't shadow. In fact, I think I picked every single one not shadowing. Brilliant. This one was a little different looking, but supposedly the same thing. This one's kind of breaking the rules too. It's kind of round. It's wider than it is tall. A lot of times with cancer, we say taller. We say taller than wide leads us towards cancer. Wider than tall leads us towards benign. This one's not benign. But when you look at it really close, you can kind of see there's a little bit of a fuzzy edge. Once again, not a great image. Same thing, a couple of calcs in the middle of that one. Some lobulations, indistinct borders. Not 100% sure where the tumor begins and ends on that one. Same thing here. Where does it begin? Where does it end? And yeah, this I should have gone to here first. This echogenic around here, that's the least of which it is reactionary. But researchers believe that those are actually speculations as well. They just can't see the details of them. All right, let's see. Okay, well, invasive lobar carcinomas. In ILCs, invasive lobar carcinomas, those are 10% of the carcinomas overall. So the ductal carcinomas are by far the more common, but this is number 2. Number 2. Well, number 2, invasive. You know what? 10% of all number 2, yeah. These can be multifocal. In other words, if you see one, you might see more, possibly bilateral. Bilateral. That's a B, not an L-O. This case, I would say this is, Mets to other side. So earlier I was saying that, it's you just genetically, if you have one in situ, you might have another. But with the invasive, it could, let's put a question mark here. It could be metastasized to the other side because these guys are a little more aggressive. Diffuse tumor does not cause fibrosis, right? So it's a diffuse tumor and does not cause fibrosis. And your book threw a beautiful word in there. Desmoplasia. Desmoplasia is causing fibrosis. People just kind of threw it in there. Mammal, I'm just going to say good chance it will be missed because it's diffuse. And if it's a diffuse tumor, mammography might not cause it. Oh, diffuse tumor, and furthermore, does not cause fibrosis. Well, fibrosis is easy to see on X-ray, on mammals. So that's kind of a double whammy for this guy to go unnoticed. And with Sano, I called it a hypo, if you see anything, echoic ghost. That's my terminology, not anyone else's. And let's see, where did I have my hypoechoic ghost? Oh, yeah, better. All right, well, I guess I remembered a different image that I had. Maybe it was a different cancer than I was thinking. But yeah. In any case, this one's hard to miss. This guy's hard to miss. Very lobular, really long, which, you know, once again, not typical of a lot of cancers, but still it is there. And then this one looks very different. In fact, these look so different that I'm going to double check. I feel like okay. Maybe we'll take a break fairly soon anyway. I might have to, I want to double check my images on that. I feel like I need something. Let's just go. Well, I tell you what, that kind of threw me off. Let's take a break. We'll come back at 2 o'clock. I should have just used this article. This is well, I'll pass this along to you guys. Let's just quickly we'll kind of just go through the pictures. Okay. Normal breast parenchyma. This looks great here. You know, skin, pre-mammary the fat, and then the fibroglandular layer, and then retroglandular, really thin on this person, this woman. Let's see, breast cysts. So a couple of good simple. Well, mostly simple. It's probably just most of that's probably just noise in there. This one's got a fluid level, so something's going on in there. And then this one's really homogeneous. What does it say about C? A galactocele. Ah, well, there you go. Galactocele. Oh, this one says inflamed cyst. I've been looking all over for a picture of an inflamed cyst. With internal layering of thick, thin fluid arrowhead. Here. Well, I don't know. And then D, seeing this extended view, or also called panoramic view. Our machines don't do that, unfortunately. Shows an irregular pseudo wall with dirty internal echoes due to pus or debris. So kind of that looks like certainly an infected, reveals diffuse chronic abscess. Yeah. Fibrocystic condition or fibrocystic change. I guess everyone's got to use their own words for this. Just an increase. Here's a fibro, and there's a cystic, fibrocystic change, and both of these are extended field of views. This is just duct ectasia. And it doesn't say really why. There's some debris. You can see debris in the duct here and here. Fibroadenoma, well, that's perfect. It's wider than it is tall. It has a bit of just a thin halo, or at least part of it does. Through transmission, really, is not even shadowing. Actually, it's through transmission, which, well, not a whole lot of solids do that. But and then the cousin, the giant cousin, the phyllodes tumor, or the cystosarcoma phyllodes tumor, is very much closely related, but it grows so big, it gets cysts inside of it. That's probably cystic degeneration. See, well-defined margins in mitochondrial structure, sometimes various systems. Change is low. The incidence of malignant change is low, but not zero. So, and these things are huge anyway, so they probably just want to remove those. Oh, nice little lipoma. Man, that's crazy. It looks like someone just put a magnifying glass on there. But that's crazy looking lipoma. Malignant lesions. This is why I opened up this. We have the arrows here are pointing to spiculations. So the spiculations on ultrasound are not, they're pretty fuzzy. Well, everything in ultrasound is fuzzy, right? They're not as delineated and sharp as we see in mammo. What does B say? Obviously it's ugly, but some nodules reveal a branching pattern. Okay, yeah, it's branching out a bit. Sagittal view C shows a nodule with multilobulated margins. The presence of more than 3 to 4 lobulations is suspicious. So they're not this one has a combination of micro and macro, but the macro lobulations, you can only have so many before they start saying, okay, that gets a little scary. Let's see, D and E scans show duct extension. M indicates primary site. Cancer started here and is extending through the ducts. It looks like we have microcalx here. It shows a typical malignant lesion with irregular spiky margins, microcalcifications, and branching pattern. BI-RADS category 4. Why wouldn't they just go with a category 5 on this one? But there's microlobulations, there's some macrolobulations, and I guess the difference between a macrolobulation and a branch is hard to know. Certainly calcifications in there. I did a little 3D on this one. Let's see, malignant lesion shows smooth margins suggesting a category 3 3D image in the corneal plane. However, reveals spiky margins with sunray appearance. So with 3D, they're getting more evidence of spiky margins here, and this was just not a great picture overall. Internal vascularity, but look at this. This is almost a bilobed, wider than tall. So and we could have easily have said this is a fibroadenoma, but there's probably a little bit too much vascularity in there. Let's see. And then, finding Finding and the predictive value. Speculation, 92% basically. Taller than wide, 81. Angular margin, 67. Shadowing, 65. Branching pattern, 64. Hypoechogenicity, 60. Calcifications. Oh, we're starting to go down to maybe calcifications around about 50%. Duct extension, 50%. Branching pattern. Microlobulations. Huh. I think they made a mistake. But in any case, you kind of get an idea of what's more important. I would say these are the most important. Calcifications, microcalcifications are more important than macrocalcifications. And duct extension, yeah. Anyway, thought that was pretty good. So I was not wrong. I just thought I had a different picture. I thought I had a picture that looked more like this. So, yeah, invasive lobar diffuse tumor does not cause fibrosis. So, I don't know. I mean, this definitely looks like a diffuse tumor. You know, if my writing surface has been taken away from me here. Certainly kind of goes off in different directions, and it's really hard to say where it begins, where it ends. This one's hard to see where a tumor really is. Even we just see shadowing. But this one looks very different, and I double checked. I found this again, and yeah, invasive lobar carcinoma. So, but I guess it just goes to show that we don't always know what we're looking at. Damn it, with ultrasound or with mammo. These guys just kind of do what they want. Anyway, medullary carcinoma. I wrote some of this down because I had a lot to write down. I wanted to. Medullary. I'm going to write something over here. What did I say? This one. This one breaks almost all the rules. So this one's kind of a pain. This one can easily be missed. Even when we see it, we can miss it. So first rule, hits younger women. That's kind of a broken rule there, because not that any of these cancers can't affect younger women, it's just less likely. Well marginated and circumscribed. Well, that doesn't sound like cancer. That sounds like a fibroadenoma. No reactive fibrosis. Some of them do, some of them don't. Why is there a square cut out of my? That is weird. Right? I see things like that and I think, uh-oh. All right, mobile. That does not compute with carcinomas. And soft, once again, that does not go right. So, well, and ultrasound, hypoechoic, well, that actually works, and vascular, that works. Halo, actually, we see those with fibroadenomas, so that's not normally something we see, in the breast, different parts of the body, yeah, not the breast. And multilobular, okay, well that too. So if it's too many lobes, that does become suspicious. So that's over here. The medullary. So I only grabbed a couple. So medullary carcinoma. Let me look at this. It's not invading anything. So this is also, but And it has a pretty, we know exactly where it begins, where it ends, top, bottom, right, left. If you look really closely, though, there are microlobulations on that. There's through transmission. Once again, that is not expected with cancer. So these guys can really. That's why the doctors they know that just because we have ways of saying, "Ooh, that really looks like cancer," or "that really doesn't look like cancer," they know that they're going to have to stick a needle in it. Once again, over here, definitely some lobulations, perhaps too many. A little bit of microlobulations anterior, and some multiple, a little bit larger lobulations posterior. Hypoechoic calcifications. Probably some calcifications in there, but once again, colloid, and these are going to start coming at you a little faster now, guys, just so you know, because we're getting into rarer, and so, but a colloid, just like a colloid cyst is a thick cyst, and so this is a thick fluid just a little closer. Mucin is what's basically found in these. Older women, as in like elderly, are more likely to get a colloid carcinoma. It can be mistaken, question mark, for fat or fat lobule. And they can have through trans, but I think the images I have don't. Oh, no, they do. Yeah, they do. Certainly this one looks just like fat. That'd be very difficult to find. And of course, in an older woman, the breast is practically 100% fat. The fibroglandular tissue is so recessed in an older breast. And here again, here's another one. Isoechoic. You can kind of see that this is different, though. So you should be able to find either one of these if you know where to look. But this one's a little bit easier. But still, isoechoic could be considered, just another fat lobule. And then, finally, the intracystic papillary carcinoma. That is basically the papillary tumor that we talked about before. We had a benign version of papillary. Now we have a papillary carcinoma. So it is transformed into carcinoma, which doesn't happen a whole lot. And in fact, that's what that one is there. It is rare. Most of these, and this one is actually slightly more common in men. Are actually slightly more common. They have papillary carcinoma. We'll talk just very briefly about male breast cancer. Yeah, I already mentioned is a malignant transformation of papilloma. So you had this papilloma, and the doctor said, "Don't worry about it," and then it turned to cancer. But you were a rare case, but it does happen. So that's why they should take papillomas out. And it looks similar to the papilloma. So I think I got one image here. So remember, the papilloma, if it creates its own cyst because it blocked off a duct, then it's called intracystic papilloma. The same thing with the carcinoma. If it blocks the duct and creates a cyst, it's an intracystic papillary carcinoma. And you can see it growing into the cyst like that. And you don't know until you stick a needle in it. Tubular carcinoma. And then, last two of the carcinomas. Tubular, what do I have? I got another rare on this one. That's RA. Tubular, these are going to be in the TDLUs. So that makes them likely more peripheral in location. These tend to be small, hypoechoic spiculations. And I do have I can't remember. I do have a picture. Yes. So a SAG and trans or rad or anti-rad, one of the two pictures here. I think on this one, you could really see, let's get another color here. You can see that there's the main tumor, but then look at this reaction out here. And so the tech kind of, like, I think the tech was kind of like, do I really put my caliper all the way out here or not? And so they kind of fudged it and put it halfway between. It happens. But yeah, you can see extension of the tumor going off in that direction. And then last one, and I don't even have an ultrasound picture for it. I'm stuck here. Inflammatory carcinoma. Now this one, I had to do a little double checking on this because I wasn't 100% sure. So often, and I've done this in the past, and when I've taught this course, I get to inflammatory carcinoma, I always say, you know, what exactly is it? And I believe your book said it was it your book? I think so. Basically, it's a subset of intraductal carcinomas. But it is invaded lymphatics of the skin. Because so often when I look this up, it's just simply, they just call it its own carcinoma, inflammatory carcinoma. It's like, okay, so where did it start? Where did, you know, what kind of tissue did it come from? And so often they don't really tell you, and I think I finally, this is like literally the first time I ever really got an answer, is that it's a subset of the intraductal carcinomas. So there's a number of different kinds could be involved. And that's probably why I never get a straight answer, is because it could be a number of different carcinomas that cause this, but once they've invaded the lymphatics of the skin, it's going to have some effects on the skin, and we've already mentioned that. But this could also be missed. So the tumor, the IDC tumor, might not be seen. You also might think it's mastitis. Question mark. You think it just looks like mastitis, looks edematous and angry, as it were. I already mentioned tumor may not be seen. And finally, we get the pew, and apparently it's just de orange. And so I finally got a picture for you, and you could see now why it is called the orange peel. All the little hair follicles are kind of retracted. It's not so much that they're retracted, it's the skin around them is all swollen. So that is a common appearance there. One thing in your book mentioned nodal spread, and these levels were really axillary only. Now remember, axillary nodes aren't the only nodes, but they are the most common. Most of the lymphatics go to the axilla, and so that's a standard part of your exam, is to look into the axilla. The first node that it goes to is the sentinel node, and that's probably going to be in a level 1. And level 1 is, well, it's just low axilla, and and then mid, and then high up in the armpit axilla. That's all I want to say on that. Levels 1, 2, and 3. Look at all this. Oh, I am so excited to be almost done. Okay, easy stuff now. Easy peasy stuff. Now, I was at a pool a couple of years ago, and there was a man. So, by the way, when a man's really obese, that's not gynecomastia. That's just fat. I mean, but gynecomastia is a problem where the estrogens, and men have estrogens too. We have androgens that predominate. But if our androgen level goes down and or our estrogen level goes up, men can develop rudimentary breasts. And I've seen this a number of times. This guy at the pool, though, it was just so uncomfortable. He had these, it wasn't fat, it was breasts. It was like, dude, why would you, why? Okay. Anyway, so gynecomastia. I've seen this a couple of times. I've scanned one man with, they were nice. I mean, I don't know how else to say it. They were well-formed breasts, and he was a bodybuilder, and he was taking testosterone, and then he dropped the testosterone. He just stopped taking it, and his body couldn't catch up with his own natural testosterones. So the natural estrogens in his body predominated for a while, and not to mention, not only did he just stop, but he probably, when you take testosterone or steroids, when you take steroids and you take them in large amounts as a male, you might destroy part of your endocrine system. You might destroy the ability to create your own testosterone. So a lot of men, when they get off steroids.
I have a question. So, like, if a guy takes testosterone, does he have to take it like his entire life in order to prevent himself from getting that?
If we're talking about like medically prescribed testosterone, probably not. But if it's medically prescribed, it probably means that he needs it anyway. If you have low testosterone, you're certainly not guaranteed to get gynecomastia. Oh, one thing, guys, and this is just me. Never feed boys, or with a D, boys soy. Lots of plant estrogens in soy, and it could affect boys, and it could affect them negatively. It affects little girls too. They actually can have like a precocious puberty, or let's say early onset of no, I'm not going to say it. I'm just not going to go there. They might learn about themselves a little earlier than expected, like a lot earlier than expected. Let's just put it that way. So yeah, gynecomastia. So and I've done a couple of ultrasounds on men like this, and it looks like breast tissue. It looks like fatty breast tissue, because it's not. So men, male breast cancer. Well, okay. Well, we'll go right into male breast cancer. I didn't even write anything down for this. It is rare. We can get most all of the same cancers that women get, but it is rare because we have very little normal breast tissue. And if we do get breast cancer, it is almost always retroareolar, because that's the only place where we have rudimentary breast tissue is behind the nipple. So you're probably not going to find it far away unless the gentleman's had pretty dramatic gynecomastia, and it's the glandular tissue has really grown. But for the most part, in gynecomastia, it's fatty tissue that's growing, not anything else. Augmentation. Well, I don't know what you guys are thinking. This is just I was just drawing my little guy here. Anyway, augmentation. You could have retroglandular augmentation. So the saline, or my God, it's on the tip of my tongue. For God's sakes, Kurt. Silicone. Good Lord. I was like Silicon Valley, either they could be put retroglandular, so basically on top of the chest wall, posterior to any breast tissue that's left over. And this woman discovered that if you put a powerful flashlight through them, they will glow. So I just thought that was kind of cool. You could do this to babies' heads, by the way, and I'll show you some dramatic pictures of babies with fluid-filled skulls and how their skulls will light up like that. Retromuscular or retropectoral is another way of doing this. So subglandular is this first one here. And you can see the pectoralis muscle goes behind. it's a good sized muscle for a woman too. She's a strong girl, but you know, it's the top edge of the implant there. And then retropectoral, here's the pectoralis muscle up here. And so that is down behind the pectoral. Generally speaking, and I think, you know, it's regional and different doctors, different things. Subglandular, this is more the cosmetic. And this one's a little more reconstructive, but not necessarily. A woman can choose, or a doctor can suggest either one for cosmetic or reconstructive surgeries. Doctor's preference, patient's preference. When we look at these, and you will be asked to look at them, this one's got a normal fold. They're not perfect. They're not going to be in there perfectly, like a perfect balloon. It's more like a balloon shoved under a bed or something. And so there's going to be some folds to it, and that's okay. This one, let's see, yeah, it actually has. You're more likely to find 3 layers with the silicone, and this is a silicone one. Yeah, there's this inner layer, outer layer, and let's see, fibrosis, yeah. Well, in any case, this layer is actually human tissue, and that's fibrosis out here. And so it's a foreign body, even though it's not going to react terribly with your body. It is a foreign body, so fibrosis is a normal reaction of the body to wall off a foreign body. So you should see that. And then here's a saline implant. And one way we know it's a saline implant is that it has a port for a needle. Needle goes in. Ooh, that's a horrible looking needle. And then adds more saline if they want. So a port is normal to find with a saline implant. You can't really do that with silicone. It's too thick. You'd have to have like a garden hose to shove it in there. That probably would hurt. And I suppose that's why they now have saline / silicone implants, so that the silicone is supposed to feel more natural, but the saline is something that you could add to it at a later date, either because you want larger breasts or because it's just simply easier to stretch the skin slower with a saline implant. Silicone implant, the whole thing has to go in at once, no matter how big it is, right? Yeah, pretty much. One reason you're going to look at them is for rupture. On MRI, this is called the linguine or lasagna. This might be lasagna. They get in the pasta in the MRI. I don't know why, but linguine sign, whatever. But for ultrasound, it's called what's it called? Stepladder or parallel sign. So you know, it's just, here's your outer layer, and then it's folded over and folded over and folded over. God, that thing must have been huge. So that is a rupture there. And then the other thing with ruptures is, you know, if you have, that was probably a saline implant too, because saline is going to come out a little bit easier, because silicone is really, really thick. And here we have a leak at the edge. So here's the actual implant there. And silicone has this reaction with the skin. So even though it's hypoanechoic over here, once it gets into skin tissue, once it gets into the tissue, there's an inflammatory reaction, and it looks like inflamed fat, actually. And that's also, oh, what's that called? Siliconoma, which kind of a pseudo tumor, but that's what it is, siliconoma. And then, oh gosh, what do we even have down here? Oh, that's right. Acute hematoma. Oh, that looks painful. That looks painful. I don't know what caused this, whether it was a blunt trauma or maybe the surgery itself, and it bled after surgery or after implantation, but you can clearly see this is, well, I mean, the implant's here, but this is all hematoma over here, so you got just blood and clotted blood all through there. Think. And okay. Oh, and so I skipped in the chapter Doppler. I skipped interventional. You know, suffice it to say, we could. There's a lot more to say to interventional, but you know, I don't know. I just figured we got more important stuff to hit. Okay. Done with breasts. When are we going to test on this, guys? Monday or Tuesday?
Never.
Oh, okay, that's a good idea too.
Monday is a holiday, so can we just skip Monday?
That's right. Oh, good. I'm gonna finish my shed. Oh, that's good. I got to stucco it. You have to stucco like every day. So good, long weekend. Perfect. I'm gonna start stuccoing tonight. I don't know how to stucco, so it's gonna be a disaster, but that's all right. All right.
So Wednesday.
Wednesday. Tuesday, Wednesday. Well, we could, I don't know. No, let's just, because Tuesday we're going to start talking about something else. I mean, can't remember. Can't even remember what we're going to next here. Oh, fun. Fun, fun, fun. The scrotum. Well, you don't want to stop recording before you say something stupid.